So, thank you, PortsCon organizers, for giving me an opportunity to talk about scapular fractures. Everybody is sleepy. This is a vast topic. I think I may overshoot time also. Sorry. So, coming to scapular fracture, when and how to be done, I will be going through these headings. I will try to make it fast. So, anatomy, everyone knows that the parts are the acromion, the coracoid, the glenoid, the neck and the scapular body. There are 18 muscles attached to it, of which supraspinatus, subscap and infraspinatus originate directly from the scapula. So how it is injured? It's a direct blunt trauma, high velocity trauma. The traumas can happen like this: road traffic, fall from height, other injuries from. Why the scapular fracture is easily forgotten in the polytrauma? Because it's associated with other injuries, which is more fatal, easy for conservative treatment, strong belief that it will always heal. These make scapular fracture or most of the time forgotten. This was a state of pelvic fracture also in the initial days. If the pelvis is there in the lower part, scapular fracture is in the upper part. So, coming to associated injuries, there are rib fractures, the thoracic cavity injury, lung injury to the shoulder girdle, head injury, other injuries including pelvic bone, humerus, femur and all. So this fracture usually gets the least wanted respect. But it is always not like that. You should never ever forget about this injury. You should not miss it. Scapulothoracic dissociation, it is actually the whole scapula get pulled out from its natural position, leading to neurovascular injury. It is a fatal injury which may lead to death. Why there is no consensus in this treatment? Because it is a rare fracture, no standard method of measuring classification of displacement, influenced by associated injuries. The other associated injuries which are more fatal take over the scapular fracture. Only little case series and expert opinion, no evidence-based medicine. Clinical features: the area of the scapula gets swollen, severely tender. What are the images you can have? You should be thorough about the anatomy of the clavicle in the X-rays also. You should go point by point. Acromion, clavicle, coracoid, glenoid, scapula, humeral head, lesser tuberosity and greater tuberosity. Otherwise, there is a high chance that you may miss the fracture. The views which will be helpful is the scapular wide view, shoulder lateral view. Even in the chest X-ray, you should be looking through the scapula if it's only available. If there is a pain in the scapular region, axillary view is one of the good views to assess the coracoid fracture, the acromion fracture. Now, if you have the opportunity to have the CT scan, get the CT scan done, but the CT reporting, everything should be surgical parameter based. So, you can get a CT reconstruction with the subtraction of the humeral head. Coming to the classification, these are the parts of the scapula. 10% of the fracture occurs in the processes that's in the acromion and the coracoid. Around 7% it's the processes, 10% the glenoid fossa, 25% in the scapular neck, and 50% in the scapular body. Other small part is the combined and comminuted fractures. A lot of classifications are there. For coracoid fracture, the most followed classification is the Iron and Brooks classification. For acromion, you can go with Kunf classification. For glenoid fractures, the articular surface fracture, Heidelberg classification is better. For all these things can be included in the air classification. It's a 14, scapula means 14, the scapular process is 14A, body is 14B, and 14F is for the glenoid fossa. A word about the superior shoulder suspensory complex, why the scapula is very important. Whenever there is some disruption in the superior shoulder suspensory complex, which consists of, it's a ring composed of the glenoid fossa, the coracoid process, the coracoclavicular ligament, distal end of the clavicle, acromioclavicular joint, and the acromion process. The whole thing here makes the superior suspensory complex. This you can see there's a glenoid, there's a coracoid, then the ligament, distal end of the clavicle, acromion, and the glenoid. So the whole thing comes into a superior shoulder suspensory complex. If anywhere it is disrupted in two parts, this becomes a floating shoulder. In most of the scapular fracture, you can go with conservative treatment, that is for undisplaced fracture. Intra-articular, extra-articular fractures whose general conditions are very bad. What are the disadvantages? Sometimes the pain may be persisting, incongruity will be there, instability will be there to the glenohumeral joint, deformity of the scapula, it affects the liver arm of the upper limb. So for workers, it may be little difficult, but we will say it's okay, you can carry on. Operative management for scapular processes, it includes acromion, the coracoids, and the scapular spine, only if there is more than 1 centimeter displacement. Aim is to prevent healing in displacement, can cause impingement syndrome and compromise the rotator cuff. So this will be the complication if you leave it like that. Non-union of the acromion process of the scapula is often painful because of the muscle pull. These are all given in the studies. So how to fix the coracoid fracture? Coracoid and the acromion comes around 7 to 8%. Coracoid fracture depends on the class. You can classify the coracoid fracture, and if it's a small fragment, you can go with the anchor, metal anchor. You can put it into the base of the coracoid, and you can tie the tip of the coracoid, the fractured fragment, avulsion fragment to it, or you can use the screws. For acromion, there are two parts. The proximal acromion fracture, that part is more bony. The flimsy is the distal part. So you can either go with the plate or with the screws. For glenoid fracture, this you should not miss it, because if you miss it, the articulation will get hampered. So any displacement of more than 4 mm in the articular surface of the glenoid, it's better to fix it, reduce it anatomically and fix it. Easiest method is to go to the shoulder joint by arthroscopically, and with CM assisted you can put 1 or 2 screws. 2 screws are ideal, and fix it. Other method is open fixation by the deltopectoral approach. So suture anchors can be used to suture the labrum. If once you go through the arthroscopy approach, you can see the torn labrum, so you can reduce it and you can fix it in single sitting. Now, the most talked about thing nowadays is about the body fracture and the neck of glenoid fractures. What are the indications? Once you have done the CT, you should get all these parameters done by the radiologist, because documentation is very important. So, looking at this, first thing is the lateral border offset, that is medialization of the fragment. If it is more than 20 millimeter, that single thing is a criteria to do surgery, because it affects the liver arm. Glenopolar angle, normal angle is around 30 to 45 degree. If it is less than 22 degree, it's an indication to go and do the surgery. Then there is an angulation. Then if there is an angulation, this is an angulation. If there is an angulation of about 45 degree, that is an indication for surgery. These are single parameters on the left hand side. On the right hand side, you can have the combined displacement. That is, if the lateralization is less than up to 15 mm, you can go ahead with 30 degree of angulation. So that is a combined displacement of scapular fracture, more than 15 mm displacement with 30 mm of angulation, and double disruption where there is a scapular fracture more than 10 mm displaced and a clavicle fracture of 10 mm displacement. What is a glenopolar ankle? You make a line from the tip of the superior glenoid tubercle to the inferior tubercle, and the other line from the superior tubercle to the inferiormost angle. That substance, it's almost 30 to 45 degree. When it is medialized, this angle comes down. If it is less than 22 degree, it is an indication for surgery. All these things can be done only in CT. So, how will you fix it? Nowadays, good anatomical plates are available. Surgical, how to approach the body as well as the neck. You can have different approaches. One is the Judet posterior approach, that is an extensive devitalization approach. The other is the lateral column approach or the Brodsky approach, deltopectoral approach for anterior part of the glenoid neck and labrum. Then other is the superior approach. Coming to Judet approach, the incision is almost a boomerang-like type of an incision. The main part is the skin and the subcutaneous tissue should be elevated together. Otherwise, the whole thing can go for necrosis. You can have the whole infraspinatus fossa exposed, the lateral and the medial borders of the scapula, scapular spine, scapular neck, posterior and inferior arms of the glenoid. Posterior is lateral or semi-prone position. This is an approach through which you can see the whole posterior aspect, dorsal aspect of the scapular body. So first, the whole skin and the soft tissue should be elevated. Then the deltoid is from the spine, lateral part of the spine of the spinous process is elevated. You see the infraspinatus and the teres minor. Make a plane in between. The whole infraspinatus is elevated, and on the undersurface you can see the suprascapular nerve and the artery. So it is a big approach. Everybody will be scared to put something like this, but don't worry, if you go according to the anatomy perfectly, there is no harm in doing it. The other approach, if you are scared, you can go by minimally invasive approach like the Brodsky approach, that is for the medial border, and for the lateral border. If you want in the medial border anything to do, reduce it, you make a small incision here, and then you can reduce it, and through the lateral approach you can plate it. So, what are the things? Incision through the lateral border of the scapula, deltoid retracted superiorly, interval is between the infraspinatus and the teres minor, exposure or to the articular segment and the glenoid, interval between the supraspinatus and the infraspinatus. Elevated, then towards the end you will see the whole thing, and the whole lateral part of the scapula is exposed. The other approach, deltopectoral, is for the anterior part of the glenoid fractures. Cut approach or the superior approach is for the acromion. So implant use, nowadays we get the anatomically contoured implants. There are plates for the acromion, then there are plates for the glenoid and the neck, and the other plates, two plates, one for the lateral border and the other for the medial border, medial dorsal. It comes in a set, so you can see. This is the lateral border plate, this is the glenoid neck plate, this is the acromion plate. They are all right and left, and this is the dorsal lateral, and this is for the dorsal medial right and left. These are specific plates, and you can use it in the locking mechanism, or non-locking screws are there. But make sure the screw size in Indian patients is around 8 mm. Or 10 mm, maximum 12 mm. If you put more than that, you are going to rub on the rib. So complications, after putting all this, there are chance of complication like neurogenic, brachial plexus injury, suprascapular nerve, axillary nerve. Then the metal work, discomfort, infection and nerve injury. So whenever you put an implant, everybody says there is a high chance of infection, so don't do it. But if you have a good theatre setup, you can always operate. You have to take all the means you should have while you are operating, so you should have good CT scan and all the parameters needed if it is there to operate. So these are some of my cases. So this is a case where there is a floating shoulder, there is a scapular fracture, there is a clavicle fracture lateral, and thus I went by Judate approach, the extended Judate approach. This is a healing scar of the patient. This is a post-op X-ray. This is the plate which is used. It's anatomically contoured place for the lateral end of the clavicle. You can see the 2.7 screws. This is the 3.5 screws, and this is the medial border plate, and this is the lateral border plate. So this was a floating shoulder, clavicle lateral, the medial border plate, and the lateral border plate. The immediate post-op and the follow-up X-rays. Coming to the next case, he is a 47-year-old port maker. He wants his upper limb to be strong and in anatomical position. It was a comminuted displaced fracture. This also, I went by the extended Judate approach. So, thus you can see the medial border plate, the lateral border plate, the healing of the scar of the extensive Judate approach, and see the result to believe it. Starting from first post-operative day, you can see the IV, everything in his hand. This how, means if you fix it, they are so pain-free and they can start moving. Passive abduction. The second, third day, this is how he moves. And you can see the follow-up. Coming to the next case, 63-year-old, it's an RTA. He had multiple rib fractures. It's a flail chest, wet scapula fracture, and clavicle fracture. Floating shoulder with multiple rib fracture. Severe pain. He wanted operation because it was of the pain. So this flail chest actually is in the posterior part. You won't even see it. But the patient is having so severe pain, so he was taken to the theatre. The rib fractures, there were 6 ribs to be fixed in the flail chest. This was the anatomical plate by Sindhis for the ribs, fixed by our cardiothoracic surgeon. He did it and gave the patient to me. We went, this was a CT scan of the scapula. So you can see the angles and all, but it's a double disruption. The clavicle has been fractured and the scapula has been, it's a floating shoulder. So we went by the lateral approach, the Brodsky approach to fix the scapula, only lateral, and the clavicle also was fixed. You can see the clavicle, middle third clavicle also is fixed. Now, how he will be? This is his post-op function. He's so pain-free. He was wincing in pain. He was actually, one of his whole lung was collapsed. All this came back. The chest tube was here, or it was also removed, and then he started having function like this. By 7th day, he was discharged, fully functional. So, if you only when we do that, you will see the results. This is the 4th case. This is a spine fracture with scapular fracture. Whole comminuted scapular fracture. This I did with the spine surgeon Dr. Sandesh at Kannur BMH. So this is his follow-up X-ray at 2 months post-op. His fracture was united, and you can see his. This is his function at 2 months. Burst fracture, it was a burst fracture one which our spine surgeon Dr. Sandesh has fixed, and along with it, the same days after fixing the spine, we went and fixed the scapula. This is also a Brodsky approach, minimal approach. Thank you.
Rajanish, when you're floating, which will you fix first?
Ideally, you have to fix clavicle. But the case in which I have shown no, I fixed the scapula and then went ahead and fixed the clavicle.
Always.
But anyway, if you can reduce it, there's no harm in doing it. You make your
Ideally-
life, you are trying to make your life simple by fixing the clavicle and coming back to scapula. For me, the patient was already in the lateral position.
Yeah.
They went posteriorly and fixed all the ribs. So
That
it
is
was
where you
easy
went
for
to.
me to fix the scapula.
Otherwise-
even in the same position, I went and fixed the clavicle also. So I went like this.
Otherwise, if you are,
Given a chance, I will fix the clavicle first and then go and fix the scapula.
in the same position or you
No.
turn it?
I will fix the clavicle in the BMH position, turn
And
the
then turn.
patient to the lateral or prone position.
And reiterate it.
Yes.
Thank you.